Now, I must thank you for asking me to give this lecture, and I should like to congratulate the organisers on putting this conference together under such difficult circumstances. I have a conflict of interest in that the implications of what I'm saying in this talk are discussed fully in this book, Cystitis en masse, which has been published recently. But don't fear, the limited income that is generated from the sales is going to be invested into the research program that is extant at UCL. I'm not keen on cliches, but the elephant in the room trope was such a close fit for the subject matter of this talk that I felt compelled to include it. Assembled in our protocol and guideline committees, we studiously ignore scientific discoveries with far-reaching implications for many of our cherished beliefs. Chris Agaris was a professor of organizational research at Harvard University, and he was a much admired academic. He elucidated the occurrence and ubiquity of undiscussables infecting the cultures of our organizations. Certain subjects are kept undiscussable through the unspoken complicity of the right-minded, and those who seek to speak of such things are at risk of being ostracized. In other work, he developed his theories of action. His experiments quantified the gulf between the apparent motivations for our actions and the true motivations that drive us. Because we lack insight, he developed reflective practice to aid discernment. These exercises catalyze a scrupulous, stringent honesty that we must come back to at a later moment. Our professed theories of action are reflected in an outpatient's consultation, where we advise someone that we wish to do an investigation and we shall review her with the results at a later appointment. That is our professed theory of action. Our real theory in action is the fact that we haven't a clue what's going on and we're arranging the test in the hopes that something might turn up. In addition, the subsequent appointment will involve another doctor, so that person can take on the task of trying to unravel what is baffling us. Now, it's a truth universally acknowledged that the assessment of the patient should commence with a clinical history and examination. This is emphasized in MacLeod's Clinical Methods, one of the greatest books written on the subject. I believe that nowadays we have adopted habits of practice which wipe the data gleaned from the clinical methods, and this is on the advice of numerous guidelines that rain down on us as in a ticker-tape parade. In our world, we are advised to follow with a urine analysis, either by dipstick or a culture. What do we do when we have the results? Well, if you think about it, nowadays we do what a committee tells us to do. These committees are large, important, powerful, intimidating, and intolerant of dissent. We cannot do science by committee, but we are dependent on science in our quest for truth. Thus, it is no surprise that the opinions of committees are too often wrong. I should ask you to consider the situation where, whether a culture or dipstick, the test proves negative. Is it really true that there is no infection? The guidelines certainly claim that to be the case, but is it true? There is a scientific answer. Science asks the question, what is the probability of no UTI given a negative test? And this can be estimated by a calculation. So, some much simplified maths, and it is not difficult. Given a negative test, the probability of no UTI is proportional to two factors. Now first, the specificity. This is the proportion of persons without a UTI correctly detected by true negative tests. It is the same as the likelihood of a negative test given no UTI. Thus, if I have no UTI, how likely is this negative result? Secondly, the prevalence. This is the probability of having a UTI given the history and the examination before the test. It's the same as the proportion of the population that does have a UTI. Now, why do we use 1 minus the prevalence? Well, you can either have a UTI or not. So the proportions of those with a UTI plus the proportion without a UTI adds up to 1. Thus, 1 minus the prevalence is the proportion who do not have a UTI. And 1 minus the prevalence is the probability that you do not have a UTI, and it's based on your judgment after the clinical history and examination. So, we call this the probability that you do not have a UTI based on the judgment made after the clinical history and examination as the prior, because it's a judgment made prior to doing the test. The likelihood is the same as the specificity, and it's the likelihood of a negative test given that there is no UTI. Whereas the probability of no UTI given a negative test is called the posterior, because it is a judgment that you make after you have the test results. Now, remember that we're dealing with a situation where the test is negative. However, whether it be positive or negative, the prior remains extremely important. And in all circumstances, we have to estimate the prevalence. And the only way of doing that is through a proper clinical history and examination. We must not make the mistake of using the prevalence of the whole population. We must try and fit our patient into a subgroup and then estimate the prevalence of that group. For example, what do you think is the prevalence of UTI in healthy asymptomatic young women who are not sexually active, compared to the prevalence of UTI in older women with diabetes presenting with symptoms of frequency and urgency? The difference is huge. Thus, the history and examination is vital in assessing the prior. And remember this, that if the test is negative, we are interested in the proportion of that population without UTI. In the young women, the prevalence of UTI will be extremely low. so 1 minus the prevalence will be high. So the probability of no UTI given a negative test will be high as well. Amongst the older diabetics, 1 minus the prevalence will be extremely low. So the probability of no UTI given a negative test will also be extremely low, such that it's more likely to be a false negative. So the prior has an enormous influence on the posterior. Given a negative test, what is the probability of no UTI? Well, it's high in the young group, but low in the older group. And without considering the clinical history and the examination, your judgment can be way off target. Now, the likelihood of a negative test given no UTI depends on proper validation of this test with exhaustive use of controls. And this was never done for any of the tests that we use to diagnose or exclude UTI. The posterior, which is the probability that there is no UTI given a negative test, will in its turn be dependent upon the scientific validity of the test. And that was never validated with the UTI tests that we use. So that we've got to worry. We need to worry about the scientific integrity of the tests, and we need to worry about whether we have sufficient control data to see the performance of the test in different populations. Now, we can use the mathematics of probability to prove that the clinical history and examination is the crowning element of the assessment of the patient. And it is a fundamental error to make the mistake of saying that the test was negative, therefore you do not have a UTI. This involves the logical fallacy of ignoring the base rate. And the base rate that you're ignoring is the prior probability. It really is a grievous error, and it's the cause of much untold misery. Our excuse is that we are following guidelines, but the cliche, we practice evidence-based medicine, we follow nice guidelines, is an oxymoron in our circumstances. So let us address that fundamental property affecting the posterior probability. The probability of no UTI given a negative test. Are the urinalysis tests scientifically valid? Well, I regret that the answer is no. In fact, we now know that they are calamitously wrong. These are seriously bad tests. It is that fact that is the elephant in the room. I want to explain a systematic problem that was brilliantly illustrated by the Nobel laureate and theoretical physicist, the late Richard Feynman. In 1974, he gave the commencement address at the California Institute of Technology. He subsequently rewrote the speech as a chapter in his book, Surely You're Joking, Mr. Feynman. He described a phenomena that he termed cargo cult science. It's a form of pseudoscience that imagines hypotheses based on the rituals of real science, but without a scrupulously honest critical appraisal of all the evidence for and against what is conjectured. A typical example is a clinical test, where some scientific practices are enacted without rigorous analysis on the veracity of the method or the results. During the 1941 to 1945 Pacific War, Melanesian villagers inhabiting the southwestern islands of the Pacific witnessed American logistic aviation activity that supplied the forces of the campaign. These natives were impressed by the wealth of supplies that were being flown into the landing strips created on their islands. They evolved religious beliefs that this abundance was being sent to them by the gods, but it was being usurped by the foreigners who were deceiving the gods' messengers by creating these landing strips. Thus they concluded that if they modeled simulacrums of the American landing zones, they would be able to encourage the heavenly bounty to land in their territory. So look at their models of goggles, aeroplanes, observation towers, runways. They look out, expecting the god servants to arrive. A conjecture becomes a wish, becomes a hope, becomes an expectation. Look at the landing strip, lit by navigation lights at night. None of this works. So what is missing? Richard Feynman described it as an utter, leaning over backwards honesty in critical appraisal of all the available evidence, whether favourable or critical, of the primary conjecture. So here are some examples where we adopt the rituals of science without any critical thought. Next generation sequencing of 16S ribosomal RNA gene amplicons. This is being deployed to identify the cause of urinary tract infection without any proper validation. And in fact, the truth is that it is doing no such thing. This is a section of glycosaminoglycan, which most of you will have heard of as the gag layer of the bladder. Another name for it is mucopolysaccharide, and it's just the same as mucus from any other organ of the body. Now, mucus or mucopolysaccharide may contain heparin, chondroitin, or hyaluronic acid, but there's no reason to think that by instilling it into the bladder is going to be incorporated into this molecule and thereby repair the gag layer. Similarly, the nitrite test is a nice, clever colorimetric test that will detect nitrite that's produced by bacteria metabolizing nitrate. But in action, it misses 95% of the urine infections that are there. And here we've got another example. Urodynamics are obtained to reproduce the clinical symptoms. Or when we submitted this to a proper clinical trial, we found that it didn't reproduce the clinical symptoms. So these examples where scientific rituals are enacted, but the data that they're producing is of no use, simply because they were not scrutinized with that critical honesty that Richard Feynman explained as being so important. These data are obtained from Kiran Gill's research, and they are the results of an enhanced culture of spun urinary sediment applied to urine samples that were checked as uncontaminated. The bars show the species distribution between normal controls and patients with LUTS. The graphs show that both groups manifest polymicrobial isolates. There are no obviously pathogenic microbes, and the two groups are indistinguishable on qualitative analysis. There is no truth in the claim that the normal bladder is sterile. It is not correct to claim that a culture result is either a contaminant or the causative organism, and there's no evidence to suggest that a certain threshold identifies the cause of a urinary tract infection. Here are similar data obtained from spun sediment cultures conducted by Sheila Swamy. And here we illustrate the distribution of species isolates between the two groups. So 25% of Enterococcus were isolated from controls, normal controls, and 75% were isolated from patients. It demonstrates that there is a difference. Now, the mathematics of difference is the same as the mathematics of correlation. What it also shows is that you cannot distinguish between the two groups, and the mathematics of distinction is the mathematics of causation, and you mustn't confuse correlation with causation. Now we must address mixed growth of doubtful significance using pooled data from our whole research group. And the pathological marker that we're using here is the logged pyuria count from microscopy of the urine. Here we have data from normal controls, and here's the mean pyuria count and 95% confidence interval. Next along the line we have LUTS patients with a negative culture, and you can see that despite the culture being negative, which is by far the most common occurrence, it does not reassure us that all is well. Here is mixed growth of doubtful significance, lying quite definitely between LUTS patients with negative culture and LUTS patients with a positive culture. So here we have clear evidence that mixed growth of doubtful significance is in fact mixed growth of considerable significance, and so this is another assumption that turns out to be a dud and is best buried at the bottom of the garden. Now this is a Venn diagram plotted from data collected by Sanchuta Sathanthia-Morthy, who was applying 16S ribotyping to the urinary sediments taken from normal controls, new patients presenting who were not on antibiotics, and chronic LUTS patients who were on long-term antibiotic treatment because of chronic urinary tract infection. There is a 90% species overlap between the different groups, and we found that we were not able to attribute a causative role for any particular species. And so this amplifies the fact that a positive culture cannot be assumed to be identifying the causative organism. And so we should be very cautious about deciding on antibiotic treatment based on the sensitivity test applied to the isolate. Now these data are from the previous slide, but I've brought up the top 8% isolates from the series. So that means to say it's not showing 92% of the isolates, but it's enough because you can see that the dispersion of different species between normal controls patients who have not been on antibiotics and treated patients renders them almost indistinguishable. I mean, it's this 90% overlap. It is worrying indeed that people are paying large sums of money to have these genetic tests done on their urine, and the results are not identifying the causative organism, and it would be foolhardy to base treatment on what is reported. So to summarize, it is necessary to assimilate the symptoms and signs and collate that data so that it informs our interpretation of the results of the urine tests that follow us on. Now, if we don't do this, then we're likely to make some crashing errors. And probably the most fundamental error that's taking place is that in the majority of circumstances where we get a negative urine test in the patients that we're caring for, the probability is that it is a false negative result, and we should never interpret it as evidence that there's no infection. But there's more to this. As I've demonstrated, the tests that we're using are seriously faulty, and they're providing us with entirely inaccurate information. And the corollary of that is that everything downstream needs to be reassessed. And in fact, the phenotypes that we've been working with, contingent on there being no urinary tract infection, no longer stand. And we need to go back to re-examine this in order to make better sense of what it is that we're working with. So, do we really have a problem? Well, these data plotted here from 1998 through to 2019, I'm sorry that I got in the way, record the incidence of patients presenting to outpatient clinics with a diagnosis of interstitial cystitis or chronic pain syndrome. The rise commences in 2002 after the publication of the EAU guidelines, which propose the 3-day antibiotic course for acute cystitis, followed by treatment decisions based on urine culture, a test that has now been utterly discredited. You can see that there's a relentless rise in this diagnosis, and that is despite the intervention of various guidelines from different bodies, all of which continue to promote 3-day course and decisions on treatment based on culture. So we are facing a crisis. It's a serious matter, and we need to stop, think, and reevaluate our practices. Now, I hope that I finished early because I want to expose myself to your questions, because I don't think I should be allowed to get away with all this without being interrogated a bit.